Good evening, everyone. Thank you for coming along to our February lecture this evening. Before we start, if the fire alarm does go off, it is a real fire, so if you just want to go out any of the fire exits here. This evening, we'll have a more ethical focus for our lecture. We're going to be focusing on racism and sexism in healthcare, and posing the question, does medicine help everybody? But firstly, I'd like to introduce our speaker for this evening, Dr. Arianne Shahvisi. Arianne is a Kurdish-British writer and academic philosopher. She holds a PhD in philosophy from the University of Cambridge and is a senior lecturer in ethics at BSMS, where she conducts research across a range of topics in applied philosophy with a focus on gender, race and migration. Arianne has written for Prospect, the LRB blog, New Statesman, The Conservation and Jacobin, and has also featured on BBC Radio and Channel 4 News, advising on policy around abortion provision and women's health. Arianne was also a judge for the 2019 Penn Science Writing Prize. So please let's welcome Dr. Arianne Shahvisi.
Thank you, and thank you very much for having me. So this evening we're going to be talking about racism and sexism in medicine, as Alice already said. First of all, I mean, it's kind of a hard talk to write this because I don't know who the audience is, so I just want to ask where you've all come from. So first of all, are there any doctors in the room? Raise your hand if you're a doctor. A couple of doctors in the room. Anyone who's associated in any way with either of the universities or the medical school here in Brighton? Okay, a few people. Any sixth formers locally? Okay, wow, lots of sixth formers. All right, any secondary school students? A few. Any primary school students in the room? Okay, good. All right, so we've got a nice spread of people. Brilliant. Okay, I want us to start then with a riddle, okay? And in the interest of this kind of succeeding as a riddle, I ask that you don't confer and you don't say anything out loud, so nobody shouts out, okay? So I'm going to put the riddle up, I'll read it out, and I just want you to have a quick think about it, okay? So, here we go. A father and his son are in a car accident. The father dies at the scene, and the son is rushed into hospital. At the hospital, the surgeon looks at the boy and says, I cannot operate on this boy, he's my son. How can this be? Okay, so without saying anything, raise your hand if you think you know the answer. Okay, quite a few people, all right, but not everybody, okay? A few of you who raise your hand if you've seen this before. Okay, about the same number as the people who just said that they knew the answer to it, okay. And that's interesting. Shout it out then, what is the answer? It's his mother. It's his mother. And there would have been people who were sat there who were puzzled right now. And I was puzzled when I first heard this riddle, okay? And there's been some research done on precisely this riddle. So there was a study conducted at Boston University in the United States, and only 15% of children actually got this right, okay? But even more worryingly, only 14% of undergraduate students enrolled at Boston University got this right, okay? When you think about it, it's totally obvious, right? It's not even a riddle. It's incredibly easy to answer this, but people were struggling. So what does this tell us? Well, it kind of tells us two things, I think. One is that sexism is still incredibly prevalent in the society in which we live, okay? We live in a sexist society. We're all making these assumptions all of the time, and sometimes we're not even realizing that we're making them. But the second thing it tells us is that medicine itself is very gendered. Our expectation there was that that surgeon was a man. The interesting thing is, it doesn't matter when you ask these undergraduates, even if these undergraduates are themselves women. Sometimes they're women studying medicine. Sometimes they're women studying medicine who one day want to be surgeons. And even they can't get their head around the idea of a woman who's a surgeon, okay? So we expect doctors to be men, and actually this study, this riddle's been changed slightly, so you can switch it up to make it about nurses and make it about women, to explore that stereotype about nurses being women, and it works just as well that way as well, okay? So we have these stereotypes about medicine. So that's something to think about gender. What I want us to do now is talk for a little while about race, because I think there are also lots of kind of myths and misconceptions surrounding race, and I want to straighten some of those out before we then start talking about medicine. So I'll say this first of all. Some of you will have heard of a study called the Clark doll study. Okay, this is by a couple of researchers in the 1940s. And what they did was they took a group of African American children, okay, and they showed them, and they were between the ages of about 3 and 7, all right, so somewhere almost 3 years old, and they showed them 2 dolls. One of the dolls was a black doll, and one of the dolls was a white doll, all right? And they asked them the following questions to these children. They said, give me the doll that you like best, or give me the doll that you want to play with. In the majority of cases, the children handed over the white doll. It was the white doll they liked best, the white doll they wanted to play with. Give me the nicer doll. In the majority of cases, the white doll. Give me the doll that looks bad. In the majority of cases, the black doll. Give me the doll that's a nice colour. They chose the white doll. Give me the doll that looks like a white child. They understood what the correlation was. They gave the white doll. They understood that the white doll was somehow modelling a white child in some way. Give me the doll that looks like a black child, the black doll. And then finally, give me the doll that looks like you. And this is the heartbreaking bit, because those little children, those little black children, handed over the black doll. So they had assigned all of these positive things to the other doll, but they themselves associated with the doll they had assigned those more negative kind of properties to, okay? And that was the 40s. Maybe you'd expect that then, all right? For what it's worth, it was worse in segregated schools, which was just showing that segregation was actually, you know, entrenching some of these racist values. But it was repeated in 2005, and the same results were found, okay? So the interesting thing about this is that those racist attitudes are picked up and internalized. They're brought into how people think about themselves from a very, very early age. You've got 3-year-olds who are already showing these kinds of views, okay? So I tell you about this simply to make the claim we live in a very racist society, okay? And as we go through the talk, there are various other pieces of evidence that I will give you for that. But let's talk about race a little bit. What do we mean when we talk about race? What does race mean as a term? Well, the first thing to say is it's not real. There is no genetic basis for race, okay? There's no scientific basis for race. It doesn't exist scientifically. This is a social category that we have created, all right? And the way that I base that on the evidence of genetics, okay? So people have studied the genetics of human beings, and they have looked at people who you would put into one racial category and people you would put into another racial category. And what they've found is that 85% of the genetic variation within human beings is within the same, what we would call the same racial group, right? And there's only 15% variation between that racial group and another racial group. So if you're struggling to understand that, the best thing to think about is these pictures, all right? So you might previously have thought about race as being the Venn diagram that looks like this. Right, so you've got one race here and another here and another here, and everyone falls into these groups. And there's a little bit of overlap, right? But for the most part, they're separate. The reality is more like this, okay? They overlap so much with each other, and the differences are just little ones around the edges. There's really not a lot of difference. There is no genetic justification for race. There's a genetic justification for all sorts of other things, including the kind of earwax that you have, right? But there is no genetic justification for race. There's nothing genetic underwriting it. So these forms that we fill out, where we have to say what our race is, right? Or these ways in which we tend to think about the race of ourselves and people around us, that's not a scientific thing. That's entirely a social thing. And I expect for some of you, you'll be sat there thinking, I'm not sure I buy that, right? And so I'm going to try and give you a little bit more evidence here, okay? And hopefully I can convince you. So here are 3 scientists, okay? Which 2 are in the same racial group? This isn't a trick question. Which 2 are in the same racial group? Does anyone want to? Which 2 fall into the same group and which is in a different one? Someone put, yeah? What's an inventor in the same racial group? Okay? Like, as I say, not a trick question, that's what we all would have said, right? We'd say that this Korean scientist here was in a different racial group, right? We'd say they were in the same racial group. So these 3 scientists had their genetics sequenced, all right? So their genomes were sequenced. And it turns out that each of these men has more genetically in common with Seongjun Kim than they do with each other. Okay? So each of these two is genetically more similar to him than they are to each other. Okay? So these visual differences that we see where we think we're seeing different groups, the genetics doesn't necessarily support that. All right? And given that this is a talk about racism, I'll also not let it pass, and I'll quickly point out that this guy, who was involved in the discovery of DNA along with other scientists, is also a horrendous racist. And I encourage you to go away and look that up for yourselves as well. So that's a big disappointment. Excellent scientist, but has turned out to have some very, very dodgy views which are not supported by science in his later years. Good. Okay. So let's talk a little bit about human genetic variation then. So human genetic variation largely comes down to the way in which genetic material gets combined, okay, but also mutations in genetic sequences, okay. I won't go into the details of this, but you can see there, these are strands of DNA, and some of those bits of DNA are being switched in mutations or duplicated. So our DNA gets copied, right? So we're continually making copies of the cells in our bodies, and sometimes there are mistakes in that copying. And those mistakes lead to greater diversity amongst human DNA. And just to give you a sense of what I mean by diversity here, so humans are not actually a very genetically diverse group. So if you sequence all the genetics of everybody in the room, we're not really that different to each other compared with other species. So the most genetically diverse of anything is this worm, C. elegans, up there. The most genetically diverse. It's kind of weird to think that if you had a sample of loads of those worms, it would be different from each other in more interesting ways than any of us are different to each other, right? Despite just being worms at the end of the day. The same for fruit flies. Gorillas are a bit more genetically diverse than we are. So in a population of gorillas, there's likely to be more genetic variation than there is amongst human beings. And then on the less genetically diverse side, we've got cheetahs, who are, notoriously not very genetically diverse, and that threatens their future existence, actually. Sea otters and island foxes as well. So these are not very genetically diverse species. So we're somewhere in the middle of that, but we're not a very genetically diverse group, okay? The greatest amount of genetic diversity amongst human beings is within the continent of Africa, okay? That's where you find the greatest amount of genetic diversity. So there is more difference amongst the peoples who live within the continent of Africa than there is anywhere else. And that's because the human story begins in Africa. And there were migration routes. So early humans left Africa, and or some groups of early humans left Africa and kind of inhabited the rest of the world. All right, and so everyone was then descended from those groups that left. Whereas there were lots of groups remaining within Africa, so there's tremendous genetic diversity there. Good. Okay. So why do we have race then? Where did race come from? When did this start? Okay, given that there's no genetic basis for it. Well, race was invented, all right? And let's just say, some of you will still be skeptical. You'll be like, how can you invent something like that, something that seems so obvious to all of us? But it was invented. And it was invented around the time of European colonialism, okay? So Europeans went around the world, stealing and appropriating land and resources, kidnapping people into slavery, making them work for free, all these sorts of things. You can see there, everywhere that's green is an area that was colonized or controlled by a European power at some point. Now, in order to be able to do the horrendous things that Europeans did when they went around the world and colonized it, they needed to feel like the people that they were harming were different from them. Okay? It's very hard to harm another human being, but if you can convince yourself that that human being is not like you, is different from you, doesn't feel pain in the way that you feel pain, doesn't have preferences and values in the way that you have preferences and values, it makes it a lot easier to do something bad to that person. Okay? And it's precisely at this moment that scientists start saying, oh, maybe these people are different from us. Maybe we don't have to show them the same level of consideration and care that we would show to people who are like us. And it's at this moment in time, for the first time, that people start to talk about race. Okay? Race was created because racism was needed in order to be able to kind of carry out the various economic functions of colonialism, all right? With the brutality that was carried out with. So that's the moment at which which race is invented. And some of you will be sat there thinking, I don't know, I can't get on board with this because I really feel like human beings look different to each other. And surely that's got something to do with race. Surely race has to be real in some sense. And I think the best way I can try and explain this to you is to think about the books on a bookshelf. So you know, some people do this horrible thing where they organise their books by the colour of the spine, which makes no sense at all, right? And it looks nice. So you've got books organised like this. And if you were to look at some books organised like this, you might think there was something important about these ones being yellow, for example. Maybe they've got something important in common with each other. But you'd only have to open the books to realise that they really had nothing in common with each other, apart from being yellow on the outside, right? So our instincts can go wrong on this. We can think that there's something that these visual patterns are telling us, when really they're not telling us anything very important at all, okay? And that's what race is like. And, you know, you get kind of silly sort of generalizations that are made. So there is a headline from The Guardian there. It says, black runners have speed genes, right? And some of you probably hold this stereotype that you think, well, you know, black runners are better than other runners, right? And if you look up there, you'll see that these are marathon runners, people with excellent, very impressive marathon times, and all of those people are from Kenya or Ethiopia, right? So you might think, look, come on, maybe this Guardian headline is a perfectly reasonable statement to make. Except that black is a term that we use for more or less everybody who lives in the continent of Africa and everybody descended from those who live in the continent of Africa. And yet the only people who've ever done even remotely well at running a marathon live in that tiny region pointed out there, right? So if you live over here, you've got no chance, or you've got no more chance than anybody else of doing well at long distance running. And more than that, we don't even know that this is genetic. Some of it has to do with the specific training regimes that people have actually developed, very sophisticated training regimes in Ethiopia in particular, and people are training in highland areas, right, which gives you an advantage as well. So we don't even know that this is genetic either. But that headline is certainly an indefensible one, right, because it's lumping together a bunch of people where only a very small number of those people would have that might have that particular advantage. Okay, the other thing you might think is, well, what about these genetic ancestry reports? You know, this thing where you spit in a little tub and you put it in the post and send it off. Has anyone done that? Raise your hand if you've had your genetics sequenced. Anyone in the room? A few people. Okay. Yeah. I mean, it's a reasonably interesting thing to do. There's a bit of a question mark above it as to what it's actually telling you and how accurate these things actually are. I can say more about that in the Q&A if anyone's interested. But the point there is what that tells you. So it looks back at where your ancestors come from, what your genes are made up of. And you might think, well, if race isn't real, then what are those tests telling us, right? But what those tests are telling us is something much, much more detailed than race, okay? They're telling us something about the geography of our ancestors. And what I've got over here is a map of Spain, and this was a study that came out recently. And it's what these researchers found is that the genetics of people within Spain can differ even down to like a 10-kilometer geographical distance. Right? So we're not talking about races here. We're talking about differences of geography that can actually be very, very fine. Okay? And so race is far too crude a measure of this. And as I say, the greatest amount of genetic variation is within the continent of Africa. So when these genetic tests get a lot better, what you'd hopefully get is a breakdown that would give you a particular group within a particular state, rather than simply saying African ancestry, right, which is a fairly meaningless thing to say, all right? So that's not, you know, this kind of doesn't dispute this idea that race is kind of a falsehood, that it has no biological basis. Okay, so race isn't real then, is that what I'm saying? And I think I said that at the beginning because I was speaking a bit sloppily, right? But race is real. It's completely and utterly real. It's just not scientific, okay? There's a difference here. As any person of colour will tell you, race is absolutely categorically real. It is felt every single day in so many different ways. It's just that it's created socially. It's not created biologically. Okay? So we made this as a social category. It doesn't have a biological basis. As I say, it was created to defend colonialism. It now lives on in the racism of the societies in which we live. It is extremely important that we accept that race is a real social category in order to be able to fight racism, okay? So that's an incredibly, are we okay? Yeah. So I just want to point to a couple of stats on this now. So over here, hate crime rising within the United Kingdom, okay? So this is a growing trend. So racism is alive and well within the UK, all right? I mean, you can see this is 2011 to 12 over here, 2017 to 18 over here, and the number of hate crime incidents rising. These are hate crime incidents related to race or religion, okay? Some of you may have seen this awful thing that was stuck up in a block of flats in Norwich the other day. This really racist statement, and clearly, however you may feel about Brexit, you have to accept that it really has led to an increase in the number of hate crimes and in the acceptability of racism within the UK. And then there was this study just a few days ago, which some of you may have seen, and the question people were asked was, when in the UK, are you bothered when you hear those from a non-English speaking country talking to each other in their own language? And it's horrifying to know that more than a quarter of people are bothered to hear another language being spoken in this country, okay? So we live in a really quite racist country, and depending on what data you're looking at, it looks like it might be getting worse as well, all right? Good. Okay, so this is all just by way of background. I just want to give you a sense of where we are. Race doesn't have a genetic basis. We live in a racist country, all right? Now I want to talk about racism and sexism as these things appear in medicine. Okay, so first of all, a little bit of history. So race and medicine have a long and difficult history. I'm going to take us back, first of all, to the period between 1845 and 1849, okay? Does anyone know who this is? This statue, which was pulled down in Central Park, New York City, just a couple of years ago. Any ideas? No? Okay. This is a guy called J. Marion Sims, all right? And he's often referred to as the father of gynecology. Okay, so gynecology being the study of women's health, and what he was specifically doing was research on women to look at some obstetric difficulties, so difficulties that can happen around childbirth. And the way he carried out this research was to buy some women, slaves, okay, some enslaved women, right, and do experiments on these women. At the time, just a few years before, the use of ether as a general anesthetic, so a painkiller to stop people feeling the pain of medical procedures, that had been introduced. So he could have used this, and he decided not to. So he was performing surgery on these women with no anesthetic whatsoever, okay, surgery on them. And in the course of doing so, he made some discoveries which have been fairly useful to modern medicine, all right? And there's still pieces of medical equipment that are used on a daily basis that are named after this man, and a statue honoured him in Central Park of New York City until recently, when it was pulled down because people really started thinking seriously about how awful his conduct had been, okay? 1932 to 1972, in Tuskegee in Alabama, a group of scientists wanted to see what would happen if they left syphilis, which is a sexually transmitted bacterial infection, untreated. They wanted to see what would happen. What happens if you don't treat it and you just let it go on and see how bad it can get in people? So they recruited a bunch of people who really had very little idea of what they had been recruited into. And these were black men, black sharecroppers in Alabama at the time. And over that period of time, between 1932 and 1972, they watched them get iller and iller and iller. In the meantime, 1947, along comes penicillin, which is the recommended treatment. Penicillin is discovered as a recommended treatment for syphilis, and none of these men are given treatment, all right? They're watched as they become iller and iller and iller. Many of them die, and many of them transmit syphilis to others around them as well, okay? All in the name of science. So, again, a massive violation of medical ethics. And then finally over here, does anyone know who this is? Yes? Henrietta Lacks. Yes, good. And what do you know about Henrietta Lacks? You've started reading the book, but there is a book, yes, and I'd recommend it for anyone who's interested that they do have a look at that book called The Immortal Life of Henrietta Lacks. Henrietta Lacks had cervical cancer. She actually died of cervical cancer, and when she went into hospital, she was admitted to hospital with this cancer, which was actually misdiagnosed at the time as well. This is in 1951. A sample was taken from her. And the scientists who then ended up working with the sample realized that her cells had a particular unique quality which made them very easy to work with in a kind of scientific research setting. So scientists at the time were spending a lot of time trying to just keep cells alive in labs so that they could work with them. But hers stayed alive and kind of proliferated quite well. And so to this day, her cell line, the HeLa cell line, HeLa, Henrietta Lacks, the first two letters of her first and second name, is a preferred cell line for lots of scientific research. So there's a building just to the side of this one called the Medical Research Building, where this is the building that we use for a lot of teaching. The one next door is the one that gets used for the scientific research that gets done here at the medical school. And they'll be using this cell line there. At no point was her consent taken for this, okay? So her cells have been used ever since then. As I say, she died of this cancer, but ever since then it's her cells that have been used, and at no point did anybody think to ask her permission to take those cells and use them in this way. It's obviously standard practice now in medicine and in research that you take informed consent. And this kind of violation was, in this case, I mean, it's no accident that in all three of these cases we are talking about people of colour, all right? We're not talking about white people, we're talking about people who were devalued, people whose consent was seen as being less important, people whose bodies and whose wellness and whose well-being was seen as being less important, okay? So it's a very difficult history, and I've only picked out a few examples here. There are plenty more as well. So what about now then? I mean, that was, a long time ago. You might think, look, things have improved. Surely we're in a much better position now and we can kind of learn from the past. Well, there are still lots of issues to do with race and medicine. So there are various myths that still proliferate about racial differences in the way that people's bodies work. And these myths go all the way back to the colonial era. When I said we needed to invent race in order to feel okay about doing terrible things to people who we felt looked different to us, right? That was the idea of European colonialism required racism, required race and then required racism in order to be able to commit the various atrocities that it did. And one of the things that was widely believed at the time, and it was a very convenient falsehood, was black people don't feel pain in the same way that white people feel pain, right? That was the falsehood that was proliferated. It made it very, very easy to treat enslaved people very, very badly, right? If you felt that they just didn't feel it, it wasn't the same, right? A study was done just a couple of years ago to look at various myths and whether people in the general population believed in these myths and whether medical students and doctors believed in these myths. And so here's a few of them. So these are myths, I have to point that out, these are not true, right? Black people's nerve endings are less sensitive than white people's. White people have larger brains, black people's skin is thicker, black people have stronger, thicker bones. None of these things are true. And in this study, the researchers spoke to members of the public and they spoke to medical students and doctors to see if they held these myths. And lots of people still held these myths, and about 50% of the medical students and doctors who they actually surveyed still believed in various of these myths, okay? So these myths are still kind of alive and well in medicine. And they have an effect on the care that black patients receive. It's widely noted across various different studies that when a black patient describes their pain, that pain is discredited. Doctors take it less seriously, and they're less able to access what we would consider to be appropriate painkillers given their level of pain. And I was just looking at a study actually earlier today which was showing that black children with appendicitis are given fewer painkillers and less effective painkillers than white children. Okay, that's a recent study. So these kinds of myths are finding their way into medical practice as well. And there are a lot of medical students and doctors who believe in what are essentially colonial era myths. Another thing to point out though is that it's not just a question of the kinds of false science that we might have. There's also the effect of racism itself. I showed you some data a few slides back about racism in the society in which we live. And racism in itself causes bad health. All right, living in a racist society is bad for your health. And so one way of kind of understanding this is to think about what happens when you're put in a kind of scary or stressful situation, right? So suppose there's someone in the room who's really, really shy, and I call upon you now and make you stand up and say something in front of everyone, right? You'd be really, really stressed suddenly, and suddenly what would happen is you'd get all of these sorts of things happening, right? You might start sweating a bit, you might start trembling, your heartbeat would go up, right? And it's called a fight or flight response. And it's a very, very, this is a normal human response to stress. Okay, and what happens is the brain creates a chemical called cortisol when you're put in this kind of situation, and that's fine. We all have stressful situations from time to time, and our bodies respond very physically to these stressful situations. But what happens if you're in stressful situations all the time? If there's a low level or quite high level constant stress in your life. That is the experience of being a person of colour in a racist society, is to constantly experience anxiety and anger in response to racism. And the continual experience of anxiety and anger, this is a continual stressor which generates a particular kind of response, and it changes your brain over time. And what it does, it can kill brain cells, it can damage the parts of the brain or cause them to shrink that are to do with memory, and it can lead in turn to all sorts of health issues. So it can lead to anxiety, depression, digestive symptoms, headaches, heart disease, high blood pressure, diabetes, sleep problems, weight gain, and as I've already said, issues with memory and concentration. So there's a wide range of health issues which have been connected to stress responses, which are connected to being a person of colour living in a racist society, all right? And there have even been some studies which have studied migrants living in societies they weren't born in, as opposed to people in a similar sort of situation in the country that they've come from, just for comparison, to look at the additional stress of living in a racist society, all right? So, as I say, it has a huge impact on people's health. And you can kind of see that in these two graphs. So when we're looking at the impact of something on health, there are a couple of things that are often quite good markers for the impact on health. And one is infant mortality rate. So this is the number of babies that die, right? So once born that then end up dying. And then the maternal mortality rate, which is women who die during childbirth. And this is in both cases quite recent data from the UK, all right? And this is infant mortality rate broken down according to the particular racial or ethnic group that you come from. So this is white British and white other here, okay? So these are the lowest mortality rates. So if you're white, it's least likely that your baby's going to die, all right? And then these high ones over here, this is Black Caribbean, this bar, Pakistani over here, Bangladeshi, up here. Okay, this is consistent with things every time we measure this data. People of colour have higher infant mortality rates in the UK. And then over here, maternal death rates there. So this is women dying in childbirth. You've got white women over here, and you've got black women here, and I think that's really quite a staggering difference there. All right, racism is costing people dearly in terms of their health, and in some cases in terms of their life. Good. Okay. So let's talk about gender for a little bit here. Or more accurately, let's talk about sex differences in medicine. That's what we'll be moving on to. So the first thing to say is that it is fairly common in medicine, and the doctors in the room or any medical students in the room will be able to testify to this, that the person who is seen as the normal patient, the normal example of a human being, is a man, right? So we think men, they're normal people. Everybody else, strange in some way, right? Different from men, and that makes them kind of odd, marginal people in some sense. And so if you look at medical textbooks, where they're depicting neutral body parts, and what I mean by neutral body parts is body parts that aren't the body parts that that are different for men and women anyway, right? So I don't know, if you're looking at an image of a human body and then you're looking at a liver, for example, right? Or a knee joint, or something like that. Things that everybody has, right? There are 6 times more male bodies in these textbooks than there are female bodies, right? It's just widely accepted that men are the normal people, right? They're the standard against which everything should be compared. So you see images like this, right? This is the sort of thing that you see in medical textbooks. And then you get this kind of thing as well, which is also very worrying. So I saw this was something that was on Twitter a little while ago. It's a Cambridge University Press textbook about examination techniques in orthopedics, which is kind of bone science, right? And these are the images of women that they're showing. And some of you look a little disturbed, which, you know, it's odd, isn't it? Why are the women shown in these objectifying ways? Like, there's a very sexist way of portraying the women in this textbook, which seems utterly unnecessary to the function of these images. So they're really quite unusual. They had a lot of complaints, actually, and they've had to apologise, the press, for allowing this to be published, because that looks like an instructive medical image, and these look odd, like they should perhaps be in a magazine somewhere or something, and not in a medical textbook. So when women are appearing, it's not necessarily in the ways that women would like to be portrayed, right? Not necessarily in ways that seem necessarily educational. Okay, so there are consequences to this, though, this idea of thinking of men as the normal people and everybody else as kind of unusual or different in some way. And the first thing to say is that when we test medication, so medication and treatments are tested in what are known as clinical trials. Okay, so you take a large group of people and you try out a new medication on that large group of people in order to see what the effects are. You want to test how safe it is, you want to see how effective it is, okay? Up until the 1990s, women were more or less never included in these clinical trials, all right? But the medications which were being developed from these research studies were being given to everybody. So the idea was that the medications would be appropriate for everyone, but they just had not been tested on women. And people, you know, the scientists at the time, or lots of scientists at the time, didn't seem to think that this was necessarily an issue, okay? So we've got women making up 50% of the population, but they're seen as being somehow a strange kind of human being, a kind of human being that's somehow specialist in some way, right? Which is a very strange way to think about it. And also, for some scientists would explicitly say, oh, well, we'll just kind of reduce the numbers a bit. Women are just kind of small men, aren't they, basically? You know, we'll just think of them that way. So we can just adjust things accordingly. And what that means, the upshot of that, is that the drugs that we have are much less likely to actually work for women than they are for men. But it's more than that. Women are much more likely to have what are called adverse drug reactions. So this is when a doctor gives you a drug because they think it's the right drug for the illness that you have, but actually the drug causes you much more harm. All right, that's what an adverse drug reaction is. So looking at the period, this is in the US, looking at the period from 2004 to 2013, there were 2 million cases of adverse drug reactions for women as opposed to 1.3 million for men. Okay, so that's quite a difference. And as I say, this has a lot to do with the fact that we just haven't tested these drugs for safety on women. And what we've learned over time, and this is why this is beginning to change a little bit, as you can see, this is recent data here. You can see that women are underrepresented as participants in clinical trials in all of these cases, all right? So you're looking at how many of the people who get the disease are women, and then how many are actually in the clinical trial, and it's always below that, right, which just isn't good enough. But we're beginning to recognise that there are lots of diseases which present very differently in women. Okay, so the kind of symptoms that women have, and also the appropriate treatments will be different, all right? But we just don't have the knowledge to understand those differences. And so doctors are not as able to help women as they are able to help men, even when they end up with the same disease, okay? And then there are some diseases that are specific to women, and some conditions that are specific to women. Things like endometriosis, for example. And these are understudied. Not enough research has been done. We do not know enough about how these diseases develop. And that just means doctors are really limited in what they can do to help women because the research just hasn't been done. And so I just want to talk about a few of the effects of this. So over here you've got a pain scale. Some of you will have at some point been showed this when you've gone in with some kind of medical issue. You'll have been given a pain scale and told, tell me where you are on this pain scale. Right? How painful is it? From 0 to 10, how painful is it? And so you have to kind of decide. And you know, the idea is that a doctor will take this into account when assessing your symptoms. You know, if it's a really serious pain, they should take it more seriously. If they're going to give you painkillers, then they should give you more painkillers for a higher pain score, if that's appropriate for the particular thing that they think you have. And what the research shows is that when men and women go into hospital with abdominal pain, right, so they describe the same symptoms, I have abdominal pain, and the doctor says, how bad is your pain? And the woman says, maybe about 8, right? And the man says, yeah, maybe about 8, okay? They get different amounts of painkillers, and women wait longer. So women are 13 to 25% less likely to get high-strength painkillers for their pain, and they will wait longer to get any pain relief whatsoever. Okay, this is what the studies are showing us, and that's when they give the same pain score as a man. When women are admitted to A&E departments or emergency rooms in the United States, they wait an average of 65 minutes to be treated. Men wait an average of 49 minutes to be treated. So women are waiting longer in order to be seen. And then a place where there's been a lot of recent research around this, because we're beginning to realise that heart attacks are an area where there is a specific sex difference that's really, really quite serious. So there's this classic idea that heart attacks affect men more than they affect women. But actually, what's, and this is known by very few doctors in fact, if you match people for socioeconomic backgrounds, so you put them into the same category for earnings and the kind of background that they come from, in lower socioeconomic groups, women are actually 25% more likely to have heart attacks than men are, okay? And when women have heart attacks, they are less likely to have what we often describe as the classic symptoms. And it's interesting we call them the classic or standard symptoms. What we mean by that is the symptoms men normally have, right? And the symptoms men normally have are left arm pain and chest pain, right? These are the kind of, what it describes, the classic symptoms of a heart attack. But actually, women very often don't present with those symptoms at all, and instead present with stomach aches, nausea, so feeling sick, feeling breathless, and feeling really, really tired, right? So these are some of the symptoms that women present with, and doctors just aren't trained to spot it. And this is why, if you have a heart attack and you actually make it to hospital and end up in hospital feeling really unwell, as a woman you're much more likely to die than a man is, because your symptoms are very unlikely to actually be recognised for what they are. And so women are unlikely to access the appropriate treatments for their heart attacks, and as I say, they're more likely to die in hospital. And that's a real failure. Someone's managed to get themselves to hospital. At that point, doctors have to keep them alive. That's a real failing of the medical profession. And in all of this, in all the data that's been taken, it is black women who fare worst of all. So you've got race and gender kind of operating in tandem here. Racism and sexism, I should say, operating in tandem. And then in relation to other diseases, so irritable bowel syndrome, right? Women are more likely to be offered sedatives, so things to kind of relax them and calm them down when they go in with symptoms of irritable bowel syndrome, and also to be given lifestyle advice. This is something that women commonly report when they go to the doctor. They start being told what they ought to eat and how much they ought to exercise and all these sorts of things, which are valuable things for people to be thinking about for sure, but men are more likely to get diagnostic tests, right? So woman goes in with irritable bowel syndrome symptoms, man goes in, the man's more likely to get an x-ray of his colon to actually see what's going on, and the woman's more likely to be talked to about her diet and the sorts of things she could do to improve things in that regard. So, you know, it's not good enough. Clearly we all want diagnostic tests because we want to get to the bottom of what's wrong with us. So there's a real issue here, and it's an issue that actually goes much, much broader than medicine, because what all the data is showing us across various different areas of our society is we're not very good at trusting women, okay? We don't trust women, and doctors are just one part of that. I've got some stats up there on rape, and what it's showing is, first of all, how few rapists are ever actually convicted, but it's also showing how few are ever falsely accused. We have this myth that women lie about sexual assault. This is what the Me Too movement has been all about. We have this myth which doesn't really play out in reality, that women lie about sexual assault. We shouldn't trust women when they speak out about these crimes that are committed against them, right? And this is despite the fact that the rate at which false accusations are made is the same as for any other offence, right? So yes, very, very, very occasionally a woman lies about a sexual assault. But at the same rate precisely, people lie about burglaries, or people fake their own deaths, or people make, you know, there are all sorts of things that people lie about, and it's no more common. It's exactly as common as lying about any other crime, and yet we have this myth. If someone says, my house was burgled, we say, well, okay, you know, why would I disbelieve you? But when it comes to sexual assault, we tend not to trust women. And it's exactly this mentality that moves over into other areas of our society as well. We do not believe women. And when women come in to talk about the various ways in which they're unwell, their pain reports are often discredited. So doctors will often say, okay, yeah, fine, you know, they'll write something down, but really they're thinking, she's probably exaggerating, she's making it up, right? So there's a tendency amongst some doctors to think that women's pain isn't really as serious as women say it is, that they have some reason why they might lie or exaggerate. And women's health issues are much more often attributed to mental health than to physical health issues. And sometimes people's health issues are mental health issues, but it is much more common that a woman goes in and says, I have back pain, and a doctor starts making assumptions about a mental health issue than it is for a man in the same situation. They're also more liable to be attributed to psychological or emotional reasons, right? So doctors are more likely to start thinking there's something else going on in her life, which is why she's saying she's had sort of headaches or back pain or whatever it might be. That's much more common than it is for men reporting exactly the same symptoms. Okay, so just to finish up then, I just want to say a little bit about the medical profession more generally. I wanted to draw attention to this thing that was in the news a couple of years ago in Japan. Some of you might remember this, where Japanese medical schools got into trouble because people found out that what they've been doing is fixing the scores of entrance exams in order to admit more men than women into medical degrees. And their reasoning was, you know, women, once they become doctors, might take time off to have children. And so they're less valuable as doctors. So we'd rather train more men. So what they were doing, they had an entrance exam to get in, is they were lowering the entry requirements for men, and making it easier for men to get in and harder for women to get in to study. And it was all found, it was a big scandal, right? And so they had to fix this, clearly. It was a great injustice against the many women who wanted to study medicine there. And so they stopped rigging their exam scores, right? This was the headline just a few months later. And women did much better than men did on the entrance exam, right? So it kind of all, so hopefully there will be lots of women who will be taking up those places now. But there was this belief that men would make better doctors. And you know, I hear this in the UK as well. I had a student in a class of mine here at the university a few weeks ago who was saying that, you know, she's interested in exploring gender inequality in medicine because she was told by a family member that women shouldn't become doctors, right? That she was told that recently. So this is very much a view that, you know, quite a lot of people hold. So there's an issue in the profession as well. It's also worth noting that there is a pay gap in the NHS. There is a race pay gap. For every pound that a white man earns in his job within the NHS, a black man earns 84 pence to do the same job, okay? So it doesn't sound like a lot when it's just a pound, does it? But you know, this can amount to a difference of about £10,000 over the course of a year. It's a tremendous amount of money, you know, when your colleague is getting that much more than you for doing the same job. And for every £1 that a white woman earns, a black woman earns 93 pence, okay? And what I haven't included the stats there on the gender pay gap, but there is also a gender pay gap, right, in operation here as well. The other thing to note too is that 41% of non-EU trained doctors, and that's a lot of doctors because, you know, the NHS draws upon the skills of people from all over the world. Lots and lots of migrants come over to work within the NHS, and the NHS absolutely categorically would not work without them, right? It would not be possible to have the health service that we have. So there are lots of people working within the NHS who were trained outside of the UK and outside of the EU even. 41% of those people have had patients refuse their care. So they've been caring for patients, and a patient has said, I don't want to be cared for by you. I want a white doctor. That's the common thing that gets said. So, you know, which I think is an absolutely astounding thing in this day and age. And, you know, the difficulty in that situation is that these people are clearly trained to serve and want to do the best by their patients and really want to put their patients' health first, even under those very difficult situations. And racist abuse against NHS staff from patients trebled last year. So this is not something that's going down, this is something that is going up. This is a very big problem. So even within the profession and within the healthcare service, there are some serious issues to be thinking through. So finally then, just a few closing thoughts from me. We need more women and people of colour in medicine, absolutely. These things will not change, these attitudes will not shift unless they're shifted from the inside. We need people who understand the experience of being a woman or a person of colour in the society in which we live, and who can bring those insights into the scientific profession, but also the medical profession. Sexism and racism, as I've argued, stand in the way of good health outcomes for all, okay? So they really, really do bring down people's health. They really do make people's lives difficult and make it difficult to lead a full balanced life. We absolutely have to recognise that we live in a racist society and we live in a sexist society, and these can be really uncomfortable conversations to have, right? They're conversations that can really challenge people. People can become really defensive and upset, but unless we have these conversations, we're not going to change the things I've just told you about. And then finally, science and medicine are tremendous achievements. The things that we can do now with medicine are amazing things. We're able to help people in ways which, you know, decades ago and certainly centuries ago were totally unimaginable. But these are collective achievements. These are things that we've achieved together as societies. And I think it's really, really important that we recognise that these achievements belong to every single one of us, and we need to make sure that all of us can benefit from them just as much as anybody else. Thank you.